Good afternoon, everyone. It's a privilege to present before you. Our study was Prevalence of Maternal Mortality and Clinical Course of Maternal Deaths in COVID-19 Pneumonia, which was a cross-sectional study conducted at a very esteemed tertiary care institute held in Pune in India. As we all know, on March 11, 2020, on March 11, 2020, WHO had officially announced that COVID-19 was a global pandemic, which created a lot of fear in all of us. And most studies were mainly focusing on the general population, and there was very insufficient data regarding the effects of COVID-19 in pregnant women or in pregnancy. Whatever available literature is present in COVID-19 infection in pregnancy is still insufficient because there's a lot of scope as always. We know that pregnant women, they are more susceptible to acquire respiratory viral infections due to physiological changes that are occurring in the immune and the cardiopulmonary systems in pregnancy. So during pregnancy, there are alterations in cellular immunity, especially in the first and the second trimester, and that's generally thought to protect the fetus, that is graft rejection by mother. These changes in the cellular immunity, they can predispose the pregnant women to infection by any kind of virus, fungi, tuberculosis. So the varied immunological changes that occur in pregnancy are like reduced lymphocyte proliferative response, diminished cell-mediated cytotoxicity, reduced number of helper T cells, reduced lymphokine response to alloantigens. The hormonal response changes, that is mainly elevation of progesterone, human chorionic gonadotropin, alpha-fetoprotein, cortisol, they also have effect, and they inhibit the cell-mediated immunity. The physiological changes that occur mainly are increase in oxygen consumption during pregnancy, the elevation of diaphragm in pregnancy, decrease in the functional residual capacity for pregnant women. Aspiration is more likely in labor or delivery process, which aggravates the airway obstruction and makes less tolerable even to brief periods of hypoxia, especially in third trimester pregnant women. So the primary aim of the study was to audit all the maternal mortality that was occurring due to COVID-19 infection, with the primary objective to estimate prevalence of maternal mortality due to COVID-19 in obstetric patients, and secondarily, to systematically study and analyze what is the clinical course of infection in mothers who had mortality due to COVID-19 pneumonia. This was a prospective cross-sectional study conducted from 1st of May 2020 to 30th of April 2021 at a tertiary institute in India, Pune, and we included a total of 871 obstetric patients who had COVID-19 infection during the pandemic and all the waves, first and second. The inclusion criteria were mainly all obstetric patients, be it antepartum, intrapartum, or postpartum up to 6 weeks, who had a COVID-19 infection detected either by rapid antigen or confirmed by RT-PCR. So entire data was collected in a uniform, consistent, and reliable manner by trained qualified doctors with use of standard performer. The data was collected based on the demographic data, obstetric data, and statistical analysis of the data was done by EpiInfo software. Critical cases, they were further studied and analyzed, find the cause for maternal mortality and the clinical course of COVID-19 pneumonia in these pregnant women. Institutional Ethics Committee approval was obtained and confidentiality of the data was maintained throughout the study. These were the parameters that were collected. The demographic data as age, socioeconomic strata of the patient, BMI, then the symptomatology and time of admission for the patient, what was the oxygen saturation at time of presentation for that patient, and duration of hospital or ICU stay, and admission to death interval. The complete obstetric history, including gestation age at presentation, indications and modes of delivery, what was postpartum status, or any associated obstetric high risk if you could find with pneumonia, COVID pneumonia. The other medical comorbidities or symptoms and findings evident in the patients, Lab investigations, complete lab routine was carried out for this patient, like all the inflammatory markers and D-dimer, LDH, the C-reactive proteins, fibrinogen, ESR. Serial chest X-rays were also scrutinized, and we could see how the disease was progressing in these cases, leading to maternal mortality. And all the cases, they were treated as per ICMR or Government of India guidelines. And at the end, the maternal outcome, whether the patient was stable or delivered or discharged, was studied. At that time, a brief systemic review by Marcus, conducted in 6 countries, had studied maternal death due to COVID-19 by 1st of July 2022. In 3 high-income countries, France, UK, US, and 3 middle-income countries, Brazil, Iran, and Mexico. And the total number of maternal deaths that this systematic review had reported was 160 by the time of 1st of July 2020. And out of this, in high-income countries, the deaths were relatively less, contributing to only 22 maternal deaths by COVID-19. And in middle-income countries, it was much more higher, 133. And mainly in Brazil, 77% in the literature. So we had studied a total of 871 pregnant women who were affected with COVID infection.
Hello, Dr. Nitika. Sorry for interrupting your presentation.
Yes.
Your slides are not moving. Can you please move our slides?
Not seen?
Your slides are visible, but it's not moving. It's still an introduction slide.
Oh. I'll look into this.
Okay.
No.
Hello. Is it better now?
Yes, you are in your first slide.
Next.
Can you move to next slide?
Just give it a moment.
Okay.
Now?
Yes, it's an introduction slide. Yes, it's moving now. We shall proceed.
So sorry for the technical glitches.
Not an issue, doctor.
So we had studied 871 pregnant women. They were affected with COVID-19 infection at a dedicated COVID hospital in India, which had reported a total of 9 maternal deaths by that time. And similar pan-COVID registries, they had reported a total of 3 deaths, which is 0.46 prevalence of maternal mortality. And AppSoncom registry, another global registry, had reported only 5 maternal deaths out of 2,398 cases, which was only 0.21% of contributing to maternal deaths. Our study, however, had a very higher prevalence of 1.03% compared to the prevalence mentioned in these 2 registries. The reason could be similar, like in Marcus et al. Study, the middle income and the lower income countries, they were contributing to much higher mortality because of the varied reasons like poor socioeconomic or low socioeconomic strata and lower immunity in these countries. So our results were the prevalence of mortality due to COVID-19 was 1.03. The cases with mortality were mostly seen in the 3rd trimester. We had a total of 9 mortality cases, out of which 5 were in 3rd trimester. And the case presented with moderate to severe illness with breathlessness and myalgia in all of the cases, cough and fever in 7 out of the 9 cases. Tachypnea and respiratory distress was seen in all the patients who had mortality further, and they were not able to maintain the saturation. Saturation was below 90% in 6 cases and below 94% in 3 cases. Chest X-rays, on serial X-rays, there was evidence of bilateral lung affliction in all 9 cases, and the lab parameters suggestive of leukocytosis, raised neutrophil to leukocyte ratio predominantly, and thrombocytopenia in 5 mortality cases. The elevated levels of acute phase reactants and inflammatory markers were also seen. So these are few results of my study that I would like to share with you all. We had maximum amount of mortality in the age group of more than 30, and maximum amount of mortality with the gestation beyond 28, that is in the 3rd trimester, as we've seen. Earlier, it was not very clear whether pregnancy itself was a risk factor for severe illness from COVID-19, but now there's been growing evidence of pregnant women, especially 3rd trimester, being at a greater risk of severe illness from COVID-19. Now, similar study by Hazari et al. In critically ill pregnant women suffering from COVID-19, they had also reported that 5 cases out of 7 critically ill, they were seen in the 3rd trimester itself. Another United Kingdom's obstetric surveillance system had seen that most women who were hospitalized, they were from the 3rd trimester or in the peripartum period. Based on other demographic profiles, the mortality was mainly seen in middle socioeconomic strata of the population, and it was just an incidental finding that the 6 cases who had mortality were normal BMI, and there was no affliction seen with either underweight or obesity. This is statistically insignificant. Now, for the clinical course of the mortality seen in COVID-19 in maternal cases, it was seen that majority of them who had a delayed hospitalization, or the time from onset to hospitalization was beyond 5 days, they showed more chances of mortality because they didn't receive the adequate treatment on time. And another form was more moderate and severe forms of diseases. Rather than asymptomatic cases, they were having mortality more, and 53% were asymptomatic. However, in severe forms, the mortality was seen in 6 cases, like 66%. The main obstetric high-risk factors that were found in our study was anemia seen in 5 cases, because in India, anemia is prevalent still in antenatal patients, and we have our national programs working towards it. And other factors were previous cesarean sections. One case had twin gestation as a high-risk factor. Another had a ruptured ectopic. Most of them had the common symptoms like fever, cough, dyspnea, myalgia, who ended up in mortality, and very few had symptoms like anosmia or dysgeusia. And all of them had shown that family members in the family were affected. However, there was no mortality seen in those family members. In a cohort study that was conducted by Jose Villar, they found that presence of any COVID symptom, it was associated with increased morbidity and mortality. Specifically, severe pregnancy and neonatal complications were highest if women had fever, shortness of breath, or systemic disease. And these symptoms were present for 1 to 4 days, and they were associated with severe maternal and neonatal complications. These findings were corresponding with our study, and they suggested that presence of any symptoms of COVID-19, they increase the chance of morbidity and mortality for mother as well as fetus, compared to asymptomatic cases of COVID-19. COVID-19 affection among family members was seen. However, mortality was not seen. It could have been suggestive that the pregnancy could have been a risk factor for poor outcome, because we know that there is altered immunity in pregnancy. All of the cases, they needed oxygen. They were not maintaining the saturation. They were tachypneic, and all of them had a prolonged ICU stay. So, few cases, like 3 cases out of the 9 mortality, they had succumbed to the COVID-19 pneumonia very early, within 2 days of admission and ICU stay. However, 5 cases were improving, but eventually they also succumbed to aggravating pneumonia in them. Nothing worked in those cases, remdesivir or any other kind of therapies, protocols that were working. So we tried to have obstetric intervention in few cases. So the lower segment cesarean section was performed in 3 cases, and exploratory laparotomy was done in 1 case for these cases for life-saving purposes. However, we are not sure about whether a quick surgical intervention was improving with preventing the mortality, or it was aggravating to that factor. And none of them were vaccinated at that time when the study was done, because at that time the vaccine was not available for those patients. For lab parameters, all of the patients, mostly 5, like we can see, they had raised inflammatory markers. The C-reactive proteins were raised in all the cases of mortality. Ferritin was raised in them. D-dimer values were very high for those patients. And 5 patients also of COVID-19 pneumonia showed that there was association with thrombocytopenia. So these were the X-rays of those patients. As you can see, there's bilateral lung haziness and bilateral pneumonia seen in all these X-rays, all 9 cases of mortality that we reported. So after initial studies, it was suggested that perhaps pregnant women were not at a higher risk of complications due to COVID-19. But there was recent data that is making it evident that from Sweden, US, and now from all over the globe, that pregnant and postpartum women, they were at increased risk of severe complications with COVID-19 infection. And affliction during pregnancy was controversial at that time because there was inadequate data. The precise extent of the risk in pregnancy was not known. It was very uncertain. And this had main effect on patients' mental health as well in all the pregnant cases. There was no established guidelines at that time for general population or for pregnant women. So out of the 5 cases, 3 cases we delivered by cesarean and 2 were preterm, in which decision for termination was very challenging due to prematurity, and conservative management was preferred with the hope of better maternal outcome with COVID treatment guidelines. However, the patient had mortality in due course of time because the pneumonia was aggravating faster, and neonatal outcome was mainly good. Babies were tested negative for COVID-19, and there was no vertical transmission seen in those cases, and they were discharged. So to conclude, COVID-19 pneumonia was an additional toll for maternal mortality, and it needs to be considered in future as an indirect cause along with other causes of maternal mortality. And the risk for poor maternal outcome with second and third trimester pregnancies, late presentation to the hospital, or severe forms of disease with severe tachypnea, and raised inflammatory markers, and bilateral lung affliction. A cautious attitude in management was must. That is, even asymptomatic to mild cases, they needed further evaluation because we didn't know which one of them was going to succumb and have mortality. Stringent protocols and national international guidelines needed, and constant updation is needed. Multidisciplinary approach with the highly skilled obstetricians, physicians, intensivists, anesthesiologists, physiotherapists was needed to prevent further mortality, and special registries nationwide or institution-wide for data maintenance and maternal audits of COVID-19 in pregnancy was the need of the hour. It's important to systematically investigate the clinical characteristics and outcomes of pregnancy with COVID-19 to provide strong guidelines for prevention, treatment, and management. And our study had demonstrated that COVID-19 related mortality was not 0, it was 1.03%, which is very significant and higher for middle income and low income countries. But this data was only from a single center and mainly of strains that were involved regionally in India, and no mutation data was available. So these results may differ due to difference in virulence across the globe. And for our relief, by Joint Committee on Vaccination and Immunization updated guidelines on 16th April, there were later And studies like these have led to the reform in the guidelines, and now all pregnants have been offered vaccination. These are references. Thank you so much.